have with the radiation oncology specialists across the country, and we would like to discuss on the trends in radiation technology that are right now there in India, and sort of discuss the technologies that are being leveraged in this domain, and what are the future roadmap being set up for this area. So before we start the discussion, a couple of brief things we would like to, before we introduce each of our panel, like to talk a little bit about APAC News Network. We are a media organization, but more focused on community building across different domains. Healthcare is definitely one of them. Governance is one. Education is another. BFSI, the finance part, the manufacturing part, enterprise, startups. So we focus on community building and connecting different stakeholders in that overall domain ecosystem. We are headquartered out of Noida with a pan India presence. For our eminent discussion today, we have a set of eminent panelists. It's our pleasure to introduce first Dr. V. Srinivasan. He is the head of radiation oncology at MIOT International Hospital from Chennai, and he also wears the hat of the Secretary General of the Association of Radiation Oncologists of India. Welcome, Dr. Srinivasan.
Yes, sir. Thank you, sir.
We have with us Dr. Rajesh Kumar Pasricha. He is the professor and head of radiation oncology at AIMS Bhopal. Welcome, Dr. Pasricha. If you can just switch on your camera. Your camera is right now off. So that would be great. We have with us Dr. Indu Bansal. He is a group director and head of Department Radiation Oncology at Paras Healthcare. Welcome, Dr. Indu.
Thank you so much, sir.
We have with us Dr. Jaskaran Singh Sethi, Senior Consultant and Chief of GI, HPB and Pediatric Radiation Oncology Services at the Rajiv Gandhi Cancer Institute and Research Center. Welcome, Dr. Sethi.
Thank you, sir.
And we have with us Dr. Abhishek Gulia. Yeah, he's just joining in. He's a Senior Consultant Radiation Oncology at JP Hospital. And I'm Rajneesh Dey, editor of APAC News Network, looking to facilitate this discussion today. So my first question to each of the panelists, basically what we would like to understand is one, if you can highlight one or two of the best practices in radiation oncology domain which are currently happening in India, and how do they compare with some of the global best practices, and if this can be done through the example of what is being specifically done at your hospital. So I'll start with you, Dr. Srinivasan.
Yes, thank you for inviting us for this topic. It's a nice topic. I always believe that radiation oncology has grown by leaps and bounds in the past 2 decades. And this is one of the important modality of cancer treatment. And if you take the way all the technology has improved in every part of India. So there are a lot of private centers and corporate hospitals which get the best machines from outside India, and the lot of techniques. For example, I can vouch in Chennai we have a center for proton beam, which is one of the most sophisticated or highly effective kind of treatment. In some sites it's very useful, and that is available in India. And there's one more center of proton has been started in Tata Memorial Hospital in Actrek in Mumbai. So that is the highest technological advancement that has happened in radiation, which is used clinically now. Apart from that, most of the centers across India have all the facilities to use high-end techniques for gynecology and obstetrics.
So you have gone on mute. So you have gone on mute. You are not audible. Dr. Srinivasan, you are not audible. Can you hear me? Can you hear me? You are not audible. Hello, Dr. Srinivasan. I think while the background we work on what is the problem at there is some technical problem in the background, I think. So meanwhile, we will go next to Dr. Rajesh Pasricha with the same question. The some of the best practices in radiation oncology that are being followed in India now, and especially with respect to your hospital, if you can brief us about that.
At the outset, I would like to thank APAC Network for taking up the
Could you hear
issues
me
of
now?
radiation.
Yeah.
Yeah, Dr. Srinivasan, now you are audible.
Shall I continue or Dr. Srinivasan will
No,
continue?
let Dr. Pasricha continue. We'll come back to Dr. Srinivasan after that. Yes, Dr. Pasricha.
So, like as Dr. Srinivasan mentioned, radiation oncology is basically a technology-oriented branch. And in India, we are at par with the Western countries in terms of technology. We have got all the IGRTs, SBRTs, SRS, SRTs. We are doing in our hospital also, and most of the people who are here, they are all practicing all these modern techniques. And plus, we have an advantage over the Western world that the numbers here are very large, and which gives us a very wide exposure and different kind of cases. So, in fact, we are a step ahead of the Western countries with the technology and with the numbers. Second thing, which in radiation oncology, which is now government is focusing on, is the increased access to the treatments. Like in our hospital, we have government schemes like Ayushman Bharat, which has not now made possible for most of the people to have this treatment. Earlier, the it was perceived that radiation oncology treatment is very costly, but now with the advent of government schemes, it has become very affordable, and since it's an essential part of cancer treatment, now most of the people are able to take this treatment. Plus, one of the another thing which is now is coming in that as a radiation oncology group, we are looking at collaborations. We are looking at the compilation of data so that we can have our own data and we can present our results to the international audience, and then we can say, "Yo, this problem is specific to us, and so this is the solution of it." We are now going in that approach that we are not blindly following what data comes from the West. Although it's a little in nascent stage, but still we are now moving ahead towards that direction. Plus, our centers now are having collaboration with all the best hospitals in the world, and we are working towards having bringing the best practices from the other countries to our country. And so, I think the future of radiation oncology is quite promising and bright, and we all are now doing whatever best possible in this domain all across the world, and we are at par. In fact, in certain steps, we are even ahead of them.
Thank you. Thank you. Let's come back to Dr. Srinivasan. Got disconnected in between. Dr. Srinivasan, if you can continue with what you were saying.
You could hear me now clearly.
Yes, sir, you are audible now.
I was only telling you like whatever the technical advancements that is happening across the globe, it's there available in India also, and it could be practiced in most of the centers and urban centers, and also where there are private and corporate centers are there. All the technology advancements across the globe is available, and in some of the national centers, like what he was saying, like in AIMS and PGI and other centers also, all the technologies that are available across the globe is practiced in India. And still, the other extreme, there are still centers in India where they have only cobalt mission with two-dimension conformal treatment or 3D treatment only is possible in those centers. So everything is there, and like Dr. Rajesh was saying, the future of radiation oncology is definitely much better, and the progression of the specialties really we are seeing in front of our eyes. It is in leaps and bounds, and the technology is advanced very much in India right now. Yeah.
Okay, sir. Okay, sir. Thank you. Thank you. Next, I'll come to Dr. Indu, ma'am. Your views, one on the trends or the best practices that you see in radiation oncology, and what is happening at your hospital.
Good afternoon, sir. And at the outset, let me express my heartfelt gratitude to APEC Network for having me here. And I think we are discussing on a very important topic about the challenges and the solutions for radiation oncology in India. So now coming back to the topic, as my previous speakers have already told, that radiation has proven it has an impressive track record, and radiation alone can treat around 40% of cancers. And in conjunction with chemotherapy and surgery, we can treat up to 70% of patients and give pain relief in majority of them. So radiation is a very, very impressive modality. And with advances in imaging techniques, with advances in molecular biology, with advances in our radiation techniques itself, now we are able to offer everything best possible to Indian patients. And we have the state of art technology here in India and practicing in Gurgaon, which is the hub of medical tourism also. So what we are saying is that now we are able to treat a tumor as small as 5 millimeter to a tumor which is as large as the whole body. So we have now we are moving towards personalized treatments. So it's a focused approach now. We are now trying to give radiation only to the target, and we are able to spare all the normal organs. So the radiation is becoming very much personalized, patient centric, tumor specific, as per the patient reports. And like stereotactic body radiotherapy or with stereotactic radiosurgery treatment options, we are now able to give re-radiation also to certain patients, which was not possible before. So, and in my hospital, it's a specifically a very neurocentric hospital. So we do a lot of benign tumors as well as malignant tumors with radiation. And we have the best of technologies. There are tumor boards which are happening, and there is cross collaboration between different streams, and there is cross pollination of ideas. And because of that, we are able to give the best possible treatment, which is available anywhere all across the world. So, as Dr. Pasricha also said, and Dr. Srinivas also said, these days we are able to offer everything possible to our patients, and because of the even the private sector is trying to help out the patients, and in public sector also government is doing its job. But I think all of us are collectively making a difference in the lives of cancer patients. And radiation definitely is a boon for every cancer patient.
Thank you. Thank you, ma'am. The same question, I'll come to you, Dr. Sethi, now. What would you like to add about the best practices that are being followed in India, specifically with relation to your hospital?
Yeah, good afternoon, everyone, and thank you for having me here. Have most of the things have already been discussed by my earlier speakers. India is not lagging in technology as far as radiation equipment is concerned these days. We have the best of the technologies, from the proton therapy to the cyber knife or tomotherapy, and all the necessary technology to treat patients is available. I think the only thing that India needs now to add on to its armamentum is the carbon ion therapy, which hopefully we'll get uh, in times to come. But at the same time, we must all be aware that there's a lot of disparity in the services of radiation across the country. I am lucky and blessed to be working in a center which has 5 state-of-the-art linear accelerators, including a cyber knife here at Rajiv Gandhi. But there are so many centers across the country, as Dr. Srinivasan was saying, which have the very basic minimum. So I think it's not only about the technology, like the presence of technology, but the penetration of technology. Because India is a big country with varied healthcare systems working across the country, and like some states have done very well with radiation oncology equipment, other states are still lagging behind. And I think that when we were students, we always would hear from our seniors that every district should have a radiation oncology center. I just checked on, we have some 809 districts in India now, but we still have 300 centers short. There's concentration of services at places in metro cities, Delhi, Bangalore, Mumbai. But what about the real India, where 60% of our population is living? So, technology wise, yes, we are there, but penetration wise, I think there's a lot to be desired.
Okay, okay, sir. Thank you, thank you. So I think Dr. Abhishek just got disconnected. So once he reconnects, I will come back to him. Now, importantly, we have heard from all the other panelists, and two, three important observations I would like to make. Dr. Sethi just now mentioned that the technology is there, but the penetration is not uniform across the country. That's one challenge. One big challenge, what all of you are saying about many hospitals adopting the technology. But overall, many of these new technologies, adopting new technologies, how would it impact budget wise, especially for the patients? Because ultimately, if the hospitals incur expenses, they have to pass it on to the patients. So, in terms of the treatment costs and how can rationalization happen there? That is one challenge. The second challenge, obviously, in terms of the penetration and standardization, if not one center in each district might be an ambitious target, but even coming closer might be beneficial. So, where are we on that front? Another very important thing is in terms of the it's a specialized skill set area. So, what are the challenges there in terms of having people with the relevant skill sets? And how is this getting integrated with an overall cancer treatment? So, again, I'll start in that same sequence with Dr. Srinivasan. If you can throw light on some of the challenges, your views there.
Like, okay. So the challenges are always there. Like as I said, the technology is available, but not in all the places. So wherever the technology is available, we are able to do treatment with the best technology. But like you said, it's financially, it is definitely costlier. But in oncology, when I compare to some of the drugs that have come into the medical oncology practice, like the immunotherapies and targeted therapies, I will still say the targeted radiation is cost effective when compared to the drugs that is being used by the medical oncologist, which actually doesn't have a big survival advantage or big benefit to the patients, but they tend to spend in lakhs and lakhs. But at least radiation therapy technology, to my knowledge, in a private setup, it will be somewhere between 2 to 4 lakhs, depending on the centers. And in government centers, maybe it will be only around 50,000 to 1 lakh. So it is still an affordable treatment, and it's quite covered by insurance. So from the financial aspects, I think definitely middle class and upper middle class patient will be able to afford the high-end technology. And the people who are below poverty line, or people who really go only to the government hospitals, the technology is not available there, and they have to treat with the technology available with them. But I could see a change in scenario. For example, in Tamil Nadu, all the government medical colleges, they've got a new true beam linear accelerator. That means even the poorest patients who go to government hospitals can also get the same stereotactic radiosurgery or a stereotactic body radiotherapy, which is used in private centers. So that changes are happening. Like what Jaskaran was saying, not all the states are behind it. Some states are really helping the poor and making sure the poor also get the best treatment. Some states still lag behind because of their own reasons. So I still think financially it might look costlier, but still compared to the medical oncology expenditures, radiation oncology is still viable, and it is cost effective. And depending on the state, the government definitely can get the best technology for poor people also. So this is something that has to be decided by the government, and we are trying to push the government to do the best from our association side.
Thank you, sir. Thank you, sir, for enlightening us on that. On that line only, Dr. Pasrich, I'll come to you. Are representing a government hospital, and one of the major challenges is the cost. And how do you manage the cost, especially from a patient perspective? And especially for the profile of patients who we know visit all the government hospitals. So, what are your views on that challenge?
See, we are lucky to be in AIMS where all the latest technology is available to us. Although it comes a bit slow because of the government purchase procedures, but we get all the technology. Regarding cost factor, like Dr. Srinivas said, it costs around 50,000 to 1 lakh. It is not so in AIMS. We are treating almost at free with all the latest technology. We charge only rupees 750. But that doesn't mean there's any compromise in quality because we are a teaching and research oriented hospital, focuses on the research. And another thing is that the motto is that poorest of the poor should get the best of the care. So with that idea, we treat the patient, and we are no way behind any private center in India. We do all the SBRTs, we do all SRS, SRTs as my colleagues are doing. But the challenge here, which mainly, so cost for radiation therapy is not a problem, at least in AIMS and PGI and other government hospitals also. Some semi-private centers do have the cost constraint of like 1 lakh, 250,000. They charge like that much. But as far as my knowledge is there, in all government medical colleges and in AIMS and PGI, PGIs do have a different cost structure as compared to AIMS. But in AIMS, the cost is almost negligible. Number two, another thing is which like other issues which as drugs, regarding drugs, Dr. Srinivas told, that is very, very true. And another challenge in drugs is that these all newer drugs are not available in government schemes. They are not available with Ayushman. They are not available with any other government schemes, and they cost quite a lot. In fact, I can tell you that they cost between 10 to 12 lakh for the entire treatment. So even other schemes of government, like we get some funds from the Chief Minister Fund, we get from PM Fund. Even those funds are insufficient to support drug treatment. So here is a treatment which is cost effective, which is having the latest technology we are having. So the government, my request to government is that we should focus on radiation oncology and increase it further, so that at least one of the pillar of the treatment which is very advanced in India should be encouraged. A few issues, other issues are there, which as a community, I think we have to take care. That is our collaboration between the different centers to offer helping hand to the centers which are not at par with the technology. That probably we are working towards that. But in general, I will say the the oncology treatment cost wise is very, 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 if I will say, affordable in AIMS and PGI and other government centers also. Uh, with a little bit of caveat attached that the technology may not be that advanced in the in the smaller cities, but now the scenario is changing. Like as Dr. Srinivas gave example of Tamil Nadu, I can give example of Rajasthan, where recently I was in a meeting and there's a new state's cancer treatment center is coming up, and where they are installing five true beam Linux. In UP, there's a state cancer apex institution where they have got all the modern treatment, and also they are aiming for proton. So all states are slowly and steadily realizing this fact that this technology and the radiation oncology branch has to be nourished and has to be brought to the forefront.
Thank you for bringing aside the same question, Dr. Indu. I'll come to you now. The cost part we heard from both Dr. Srinivasan and Dr. Pasricha. Maybe the other challenges which you'd like to highlight uh, we are facing in the domain of radiation oncology in India. You are on mute. You are on mute.
Hello. Yeah, can you hear me?
Yes,
So
yes.
I think that's a very relevant question, but let me put another a completely different perspective, which has been put around by my colleagues here. So I would rather say that radiation is the most cost-effective treatment, if you ask me, as compared to surgery or chemotherapy, because number one, radiation is an OPD procedure, so the persons, I mean the family members or the caregivers, they can continue working even during treatment. And number two, because of the advancements in technology and now the radiation, with radiation technology, the main advantage is that we are able to localize the radiation to the tumor and minimize radiation to the normal tissues. So our focus is not just on curing the patient, but our focus is also on improving the quality of life, and which is a very, very important aspect of treatment, because now our patients are living longer and longer. So if we are using better technologies, say IMRT, IGRT, or SBRT, then the long-term toxicities, they go down. So if the long-term toxicities are going down, then one-time cost is not too much, because patients are able to live a good life. So as if we compare against chemotherapy, which has its own side effects, and sometimes patients need admission for many days for managing chemotherapy-induced toxicities, or for post-surgery wound healing and all, with radiation, the side effects are very, very minimal. And specifically with stereotactic focused radiations, the side effects are very, very minimal. So if you calculate the cumulative cost of a treatment post-radiation versus toxicity, financial toxicity with chemotherapy or surgery, then I think radiation scores much, much better than any of the other techniques. Number two, as they said that in government setups, definitely they have the best of technology also, and the cost is also minimal. But even in a private setup, we never compromise on the quality of the treatment. Even if the patient is paying for a lower technology, say, even I'm charging for a conventional treatment, but if the patient needs a higher treatment, then we never compromise on the quality of treatment just because of cost. At least in radiation, nobody does that. My colleagues would also agree with that. And apart from that, even in a private setup, we have the liberty from our managements to give the best possible treatment. And in fact, even through corporate social responsibility, the hospitals also give us funds at times to help really needy patients. And with government schemes, and many of the patients, they have now TPAs, or they have third party insurances. Through that, they are able to afford treatment. And as I said, that now that because most of the patients are being getting diagnosed in early stages, so if the earlier the patient is diagnosed, the patient would need less combination of modalities. A single modality would be good enough, and the combination of treatments will not be needed. Patients will live longer, so the cost automatically would also come down. So if you see the cumulative cost of radiation versus cost of surgery or chemotherapy or immunotherapy, or for that matter, even hormone therapy, which runs for years and years. So the cost of radiation is not that much. It's not that much, and we all try to, as Dr. Pastricha also said, that as although I'm sitting and the group director for Paris Group, and what we try to do is that we try to cross collaborate with other institutions in the hospital who don't have radiation facility. So because of this twinning or collaboration between various hospital networks, we are able to give cover to many other hospitals. Like every hospital in Gurgaon doesn't have brachytherapy facility, but we try to collaborate with each other so that the cost of running an institute goes down, but still you are able to provide the best of treatment to all your patients. So the cost of treatment is definitely coming down, and even if we use the best of technology, say SBRT, or even if we treat on cyberknife, the maximum cost is around 4 lakh rupees, even with robotic technologies. On the other hand, if a patient gets a robotic surgery done, it's around 8 to 10 lakhs. So I think the cost of radiation is an overblown thing. And also, radiation usually typically runs from 2 weeks, from 1 day to 3 days to 5 days to 5 to 6 weeks. And patients have the option to make part payments, so that it's not a sudden burden on the pocket of the patient. So we need to have more radiation oncology setups because, as I said before, also radiation alone can cure 40% of patients, and in combination with surgery and radiation, these magical X-rays can definitely do magic in the lives of patients.
Thank you,
I
ma'am,
will
and
just, I will
re-emphasizing the
just add
thing that
something if,
the
about
costs. Yes, yes,
what
sir.
Dr. Hindu said regarding brachytherapy. We are the only center in the state to have brachytherapy. So all the peripheral medical colleges, they refer the patient to us for brachytherapy, and then we take care of those needs. As I was telling about head holding, that's what we do regarding brachytherapy is one technique which we are helping other state medical colleges in that.
Thank you for that information. In fact, this patient collaboration between hospital is one thing I'd like to touch later. Dr. Sethi, I'll come to you about the challenges. We heard about the cost thing. There are certain other issues also broadly. One was one of the panelists earlier said about the data in terms of the patient information that we are gathering, and how effectively that patient data is being leveraged across doctors, across hospitals for treatment purpose. Then there is a challenge about the whether we have adequate doctors or medical persons who have the, and not just the doctors, even the nurses and the other caregivers and attendants who have the relevant skill sets, the technicians with relevant skill sets. Is that a challenge, and any other issues which you would like to highlight?
Well, sir, as far as I think manpower is concerned, there are a number of colleges now who are doing the post graduation courses in radiotherapy, and their number has been steadily increasing. But having said that, still, I feel there is a gap which needs to be filled because the demand for radiation across the country has been growing steadily. The number of machines have been increasing, and so have the number of centers. So we need more, as like I would like to say, the more the merrier. Yeah. So we still struggle at times, all of us, especially sitting in the private sector, we do struggle with manpower issues. The government sector lures a lot of talent because of the whatever reasons, but I think steadily uh, this needs to be approached over the coming few years. More seats in post graduation would always be welcome. Similarly, going for medical physicist. Now, you see, the radiation is not only a medical oncologist, it is a medical physicist also. It is a radiation technologist also. So, I think one very important aspect about these two subspecialties within the radiation oncology community is the quality of personnel that we are getting. We are getting people, but many times they are not industry ready, especially with regards to the latest techniques. It takes time even after passing a radiation this medical physicist training. I'm not talking of the premier centers like BRC and these, but there are other centers also who are churning out medical physicists who would need an extra training or a fellowship or some kind of work experience at higher centers to get the skill set in place. So this is an issue. Radiotherapy technologists, again, there has been a change. It is far more. The program is far more robust now. But again, at many places, the exposure to the latest technology is still lagging for these students when they come out. So getting good radiation oncology team manpower as a whole is still a challenge which is being faced. Regarding the
Okay.
cost, I think it's very important for us to understand that most of the equipment for radiation oncology is still imported, whether it be the linear accelerators, whether it be the dosimetry equipment. I think we, as a country, have to develop our own manufacturing of these things to bring down the costs. And also, till we do that, we develop that capability, I think it's the onus for the government to bring down the duties on this equipment, because radiotherapy touches life of two-thirds of the cancer patients. So cost effectiveness can be much better once the cost of these equipments, the landing cost, comes down. And in due course, if we develop our own equipment, that will be the best thing to have. We can develop Chandrayaan and Gaganyaan. I think linear accelerators are much easier to develop than that.
Yes, that would be definitely, once the those devices are manufactured locally, logically that would bring down the costs. Coming
I
on
think
that topic,
Siddhartha,
And
I
sorry,
think
and not only the cost,
yes,
Siddhartha,
initial cost, the running cost of these equipments, the maintenance of
yeah.
these equipments, it's
So I think
equally,
government is,
but it's a financial burden on the private sector when they run this equipment.
yes,
so
ma'am, you were saying
Siddhartha,
something.
so I think India is already on a step forward, and we have Siddhartha Linear Accelerator by Sameer and Bhabatron. Some work is already being going on for developing indigenous linear accelerators. So as Dr.
Yeah,
Jasparan said,
this is
so
what I'm saying,
so
Dr.
the
Anju. We
cost,
need to
running
accelerate
cost
that.
definitely needs to come down.
Yeah, we need to accelerate on these programs because
Yes,
they are the need of the hour. And
yes.
Dr. Srinivasan is there from AROI also, and the association is also trying to encourage that we get more people to come into some manufacturing thing for the Linux, so that the availability is easier, and we don't spend our dollars buying this equipment from American and German firms.
Yes, in fact, was coming to Dr. Srinivasan with that question only. From an association perspective, how are you looking at addressing some of these major challenges, especially in terms of manufacturing devices locally? Then the gap between the not just the doctors but more the even the skilled technicians in terms of making them industry ready. So and any other issues that the association likes to highlight today. Sir, you are on mute. No, you are not again audible. Uh, you So you are not audible again. So maybe meanwhile I'll come to Dr. Pasricha in terms of how do you look at addressing some of the challenges? Because just identifying the challenges won't solve much. Maybe how do you look at uh, addressing and meeting some of these challenges?
Uh, in this aspect, I would like to say the industry has to come forward. They have to look into the size of the market, because cancer is a lifestyle disease, which is increasing day by day. In fact, it is said that in coming years, only cardiac and the cancer will remain. Means with the exception of COVID and other infectious diseases, which have now made a comeback. But this is a major chunk of disease which is there, and and India has a huge population. So there is a window of opportunity for industry to come in, and they have to realize that thing. We have enough. We have trained doctors. We have patients. Only thing lacking is the uh, indigenous equipment, and some work, as Dr. Indu has said, has been done. Secondly, with one thing which I feel is that our own community have to have trust in the technology which India is providing. No doubt, the linear accelerators which we get, which we are using now, they are from last 70 to 80 years, and they have proven their worth, and they are well established. So, as a doctor, when we go, we are getting equipment which is already has been used for years. But in India, the thing will be new. So within our own community, we have to have faith in our own equipment, and we should start using it. So these two major challenges: one is the industry, and one which we ourselves have to gear up to use that. So this is the two major thing which I think should be done. And secondly, the government should support the manufacturers. Like now, government is supporting the defense equipment manufacturing. So the health of the people is much important issue now. So that should be done from the government side. Another issue, till that is done, as Dr. Sethi said, the duty should come down. In fact, there's a, I will say, irony that the linear accelerator duty, which was earlier 2 to 5%, has now was increased in the previous budget to 12%. So one side we are telling that India should be healthy, India should be the people should be best of the care. Another side we are increasing the duty on a essential equipment, which is the, I will say, the workhorse of a radiation oncology community. So at least till the time that is done, government should look into it. That the all equipments, including the quality assurance equipments, including the dosimetry equipments, they should be available at affordable cost, and slowly and steadily the till the time the indigenous equipment come to us and they take over.
Thank you, Dr. Srinivasan. If I come back to you
Am I
regarding the
audible
role
now?
the association is playing here.
I'm audible, right? Okay. See, from the association point of view, like what exactly was being told, we are trying to persuade to the government, and we have a committee which deals with the policies that government makes. Though we don't have a representation of us in the government, but still we are trying to tell them like regarding the duty that they can reduce. And also there was a problem importing the brachytherapy isotope, importing the iridium 192 isotope, for which they were charging a huge amount. And now we have persuaded the government to make it as a life-saving medicine, something like a life-saving medicine that is very important for cure of many cancers. So we have made government to reduce the charges in importing those isotopes. We are doing from our side whatever is possible through the Ministry of Health and Family Welfare. And you know how the policy works, but we are trying hard and we are trying to fight from our side. And another challenge is the education. From the education point of view, like not everybody gets the same standard knowledge or training across India. So, as an association, we formed a college called the Indian College of Radiation Oncology. And this college literally teaches students from Srinagar to Kanyakumari. And wherever the students are, whatever technology they have, we try to bring them to one particular place, and we conduct teaching programs for them. So I can say we really do nearly 12 teaching programs for postgraduate students, and not only postgraduate students, also the junior radiation oncologist by something called for their professional advancement. And so we encourage them to participate in these teaching programs. And
Sir, you again became inaudible. We will come back to. Uh, I'll go to Dr. Indu now in terms of addressing some of these issues. What would you like to highlight in terms of what is happening?
So I think these are the issues which have been raised. They're very pertinent, and we definitely need to address these questions. And as my previous speakers have also pointed out, that the government, the public, the private sector, all of us have, and the industry, they all have to join hands together to bring down the cost of technology, to bring down the running cost of the technology, and to have more of startups which start building indigenous machines. So that is one solution. Number two, as you said, that there is a lot of discrepancy and non-availability of skilled manpower in terms of doctors, the radiation physics people, as well as the radiation technologists. So, as per 2020 data, I think there are close to 2,700 radiation oncologists and close to 1,500 medical physics people and around 4,700 RTTs, but these are not sufficient because we need at least one radiation machine for a population of 1 lakh to 1.2 lakh population. So we definitely are in shortage of people, skilled manpower, and radiation is something where good marksmanship definitely matters. The man behind the machine definitely matters. And I must very proudly say that the our Association of Radiation Oncologists of India, as well as the ICRO, both are doing phenomenal job, and a lot of academic sessions are being conducted throughout the year. So these are the top programs which are being run. But I think every week there is some program or the other which is running in one center or the other, and because of the digital technology, majority of the centers are able to attend to these webinars, and these videos are also uploaded on YouTube. So students can always go back if they have access to all these access to all this material. And apart from that, we have a lot of academic WhatsApp groups where patients discussions are being done regarding optimal management of patients, and there is a lot of cross collaboration, and there is a lot of knowledge sharing, and we keep on publishing our data in Indian journals as well as in best of the international journals, which are available to everyone, so students are able to definitely learn from them. And there are some fellowships which are being awarded by the association, where students can go for 1 month training in or 2 to 3 months training in any of the Indian setups, or even to the best of the world centers. Like I went to MD Anderson Cancer Center to update myself. So I think the government should also give some funding for the students who are working in a non on the centers which don't have the best of technology. These students should be rotated to any of the centers where the high-end equipments are present. So maybe through the in the DNB teaching programs also, maybe the association can do something, or these students can be sent for some observership to the best of centers. So I think these are some of the solutions. Like we also have some students coming from international countries who have visited our center to learn the technology. So because of digitalization, I think internet is just on our fingertips. So I think learning and a lot of AI is now coming into AI based technologies is also coming in. So we have to really embrace technology, because radiation is a technology based treatment. So it should not be used just for treatment, but for updating ourselves, for updating the students. And we as senior doctors should take the onus of responsibility on our shoulders to be a mentor for the students who are joining this branch, and joining this branch, or whosoever wants to have this knowledge. So knowledge sharing should be free, and I think it's possible to upgrade ourselves only if we have the willingness to do it. So the government, the organizations, the doctors, I think everyone has to join hands
Okay.
together to bridge the disparity among different institutions.
Sure. Thanks. Dr. Srinivasan, if you can just continue with where we got cut off.
You could hear me? Right. So I was talking about when it comes to the other specialty like medical physics and technology, like they have said, we need to have trained people in that. So there is AMP which is taking care of that. The only challenge is getting a radiation safety officer. So they have to have a special qualification and clear the RSO exam. So I have found that the number of RSOs availability in India is little less. So I have been talking to the MP people also to encourage their training much better so that there'll be no more pass outs with RSO, because an RSO is a mandatory person in any radiation facility across the country. And so in that way, we are collaborating with AMP, and we are trying to also persuade to this Atomic Energy Regulatory Board who are conducting those exams, and tell them, to select more people so that there are more RSOs available for jobs. So only they are in demand right now. And we have enough radiation oncologists, is what we say. Only thing, everybody is not willing to go to every nook and corner of India. So all of us want to work only in corporate centers, or all we want to work only in cities. But I still see, like what Indu was saying, we have a lot of WhatsApp groups, and we still see a lot of vacancies available across India in different places where it's some village or some town or area. So students should be willing to go there and work. That is the only way we can make the entire country cancer free, or we try can give the same quality treatment to everybody across India. So that is what we are trying to promote among students, to make sure that they are willing to go and work anywhere across the country and to help cancer patients.
Yes, that's very critical, that uniform treatment across. Dr. Sethi, your comments, and also would like to focus on the collaboration aspect. Uh, we know there are referrals between hospitals, and um, there are different, even within the same hospital, different domains or departments need to collaborate. How challenging is that collaboration, and where are the gaps you feel?
Well, I think so. As far as cancer treatment is concerned, collaboration is a key. So one of the basic steps that goes in collaborating the different fields, like surgery and medical oncology and radiation, is to be having a tumor board. Most of the centers in India now have adopted this practice of having a tumor board. They, if and many centers have actually got cross-linked tumor boards where multiple centers can be sitting together and discussing things. This is also being done with the help of forums where cases can be discussed. Uh, Difficult cases where multiple opinions and experience and expertise comes into play. Uh, in a center, if there's an adequate workload like we have in Rajiv Gandhi, where we are practicing a disease management group concept where you go in and practice a particular branch of radiation oncology, like I'm doing personally. I'm into GI and genitourinary and pediatric radiation oncology. So this further enhances the skill set, and it also helps in better accumulation of data, because if you're treating too many sites, then you might not be getting adequate number of patients to publish a good relevant data. Whereas if you just focus yourself into a particular subset, and that opportunity is present to you as per the place you're working in, it is very important that this data should be captured. And not only data should be captured, quality data should be captured. Now, this is very important because many a times we see that we have the number of patients, like Dr. Pasricha was saying, but do we have a quality of care, the plan of every treatment plan of every patient written in every file, which is being followed, and then somebody is overseeing that these things are being delivered, not delivered. So it's very important to bring in quality when you're treating cancer patients. And I think radiation oncology is are primarily very conscious about the quality of not only radiation treatment that they deliver, but also the care, the plan of care of the patient. It's very important that that is discussed and finalized before you go in. Patchy work doesn't help these patients, you see. It has to be a well formed treatment plan which has to be followed, and then naturally discussions on the way for any aberrations that one sees. So, managing data, having tumor boards, having a disease management group concept, these all would help us towards improving our quality and care of our patients.
Thanks for focusing on basically even the treatment plan and having a quality treatment plan, and the importance of that. So this is the
And
last round, and very briefly.
another thing I feel that we as radiation
Okay.
oncology community should be doing is peer review, which not many of us practice. Actually, that's a very good way of improving your quality, because one might think he's doing the best thing, but when different people analyze, it always gives you a better insight of what other options were available for this particular treatment or this particular patient. So it's very important to have peer, and it's very important for us to have collaboration between different institutes. We're doing a lot of work in India. We have so many patients, but we have, and we do, our number of publications increasing. Like recently, we've just sent 15 papers from our institute, from radiation oncology department itself, for the European Society meeting. But that is far and sparse. I think India has the capacity of ruling any conference with data, provided we manage our data and we capture it and then reproduce it properly.
Okay, okay, thank you. So, before we conclude, we will come to each panelist, and you have 30 seconds to each panelist. And what I would like to one point in the domain of radiation oncology, which you would like, that can be technology or that can be any other trends. But one thing which you would like to see change happening, starting with you, Dr. Srinivasan.
So, my emphasis will be that the government should change, and the government should make policies that every medical college, at least every medical college across India, will have a radiation center with all sophisticated facilities. So, because we have so many medical colleges across India, even if they make one medical college, every medical college is having having a radiation institute, radiation center. I'm sure that will be a big boon for a lot of cancer patients.
Thank you, Dr. Pasricha.
I have 2 points, not 1 point. First of all, we should not be the followers. We should be the leaders. In this, I'll give example of AI. AI has. I 3 years back, I was in European Society meeting. All the 80% of paper were use of AI, which at present we are just beginning to realize. So by the time they use AI, we will be just following what they've done. And who has got the big data? We have got the big data. And AI is all about big data. So we should be leader in that. In fact, we have put up certain projects in AIMS, and we are working towards the use of AI, and we have an innovation center and we are using it. Number two, radiation oncology should not be the radiation oncologist. I'm very sure in coming 5 to 10 years, the things will be taken over by AI as the things go as of now.
Hello.
I think we lost
I
him.
think,
We'll ask him to talk.
yeah.
Yeah.
Yes. I'll meanwhile I'll come to you, Dr. Indu. Your views.
I would say that first of all, we have to bridge the gap between the stark inequalities in the and make the radiation treatment equitable all across India, because presently a little is going to a lot and a lot is going to very little. So I think we need to bridge the gap. We need to focus more on upgrading ourselves, our centers, our knowledge, and patients should be treated as a whole. There should be a holistic approach to treatment rather than treating the patient as a body part. And of course, there should be more cross collaboration and twinning relationships between various centers and global partnerships, and more funding available for radiation treatments. And I think more treatment decisions should be given to the radiation oncologist. Currently, the radiation oncology, any oncology department is being dominated by medical or surgeons. But as we said that as radiation oncologists, we are a lot much more focused on a focused treatment, and we focus more on quality of life. So I think we have to make indigenous machines, provide the facility to everyone, and improve our treatment approaches. And uh, because we are now moving from homogeneous target doses to a personalized treatment, so radiation is going to stay, and with integration of AI and emerging technologies, and with incorporation of biological imaging, radiation, no patient, I think in future, every patient would be benefited from radiation.
Thank you. Yes, Dr. Pasricha, you got disconnected.
Actually, we had a bad weather and the internet connection went off. So I'm now logging through the mobile. So, second point which was I was making was that now radiation oncology has to gear up to be a comprehensive clinical oncologist. Along with that, because we are at a very advantageous position, because we also practice chemotherapy, because chemotherapy has one paper in our curriculum. But certain aims have started a 6-year comprehensive course which will cover every aspect of cancer. So I think all the institution and our association should look into it, that we should not be only the people who are working on a machine like a technologist, but we are a complete oncologist. We can handle drugs, we can handle radiation, and we can handle all other aspects of cancer, including supportive care, including palliative care. So we have to develop radiation oncology into a comprehensive branch, not only focusing on the machine and the technology. So that is very important for coming future. If radiation oncology has to progress, and that already is means that thing is there already in UK. They have clinical oncologist, they don't have a radiation oncologist. So that will be the I think biggest future challenge for the radiation oncology. How we develop in future as a complete oncologist, along with the AI. That are the two challenges I think we should, as an association, and we should look into it.
Thank you, Dr. Sethi. You have the last word literally on this.
Yeah. Well, for me, I think in the coming few years, I would like to see penetration of radiation into rural India also, so that we are able to treat more and more patients and they can benefit from this wonderful treatment. At the same time, I would like more indigenous radiation equipment to flood the markets, so that the cost of cancer care in general and radiation oncology specifically is even more affordable for the common man. And so that people don't have to come uh, crossing miles to a radiation oncology center to get treated with this wonderful treatment, which touches life of almost two-thirds of cancer patients.
Thanks to all the panelists. We touched upon some of the critical issue. While the general consensus was that most of the technology is available, but there is a challenge in terms of from a policy level, the adoption. Then there is a penetration is definitely not uniform. There is a gap between demand and supply, not just the doctors, but in terms of the radiation technicians. Then the way the costs can be brought down, more local indigenous manufacturing, and we touched upon many of the important issues. We will highlight and compile some of these issues and try to take it up at the necessary forum, both the governance and things, so that some action might be possible in that. On that note, I'd like to thank all the panelists for joining in today and spending your valuable time here. Thanks for the insights for all the viewers who are witnessing. Thank you.
Thank you. Thank
Thank
you
Thank
so
you
you
very
very
much.
so
much.
much.
Thanks for having us. Thank you.
Thank you.